Okay. First of all, you can see by our names who we are here, so we don't need to do that introduction. But thank you so much for all of you coming. I know you've traveled, many of you, long distances to get here. We very much appreciate that. As you can see, we're in a very fast-moving, fast-changing situation after last night with the announcements by the two senators, and so now they're coming up with another plan. But the thing that has troubled me from the very beginning is the fact that you have a major bill. It has significant impact for tribes, and we haven't really done the consultation and government to government that we should be doing. And so that's what this roundtable is all about, is listening to you and opening it up and hearing what you have to say. Obviously, moving from this modified bill to a full repeal could make a big, big difference for Indian country. And so we want to hear about that within your respective states. And with those short opening statements, let me call on Senator Franken and Senator Cortez Masto if they want to have a couple.
Well, I just want to thank you all for being here, especially Samuel Moose, who has come from Mille Lacs Band of the Ojibwe and represents the Bemidji area in the National Indian Health Board. Just want to, like we all do, want to hear how the ACA benefited Native Americans and what what's being proposed was what this Republican bill would how Indians would benefit or the reverse from it. So thank you for being here, and also want to get into obviously IHS issues and staffing issues, et cetera. So thank you, Mr. Chairman, or Mr. Vice Chairman, for holding this hearing.
Thank you, Senator Frank.
Discussion.
And I just want to say, too, both of these senators have been great champions in terms of health care, Native American rights, sovereignty, whatever it is. We've all stood shoulder to shoulder with you to try to do everything we can to make sure that there's significant input from tribes and true government consultation. Catherine.
Thank you. Thank you, Vice Chairman, for holding this hearing. And similar to my colleagues and all of you, I hear from tribal members in my state of Nevada where we have, thanks to the ACA, not only we have access to Medicaid, but the expansion of Medicaid has been instrumental. And I think this hearing today is so important to hear the impacts that any type of repeal would have on all of your communities. That's what's been missing in this discussion, is the real people that are going to be impacted by the decisions that some of our colleagues want to make here in Washington. So I want to thank you all for being here this morning, and I look forward to the conversation.
Great. Well, why don't we kick it off? We're just going to go from the left around the horseshoe here.
Great, thank you.
Cheryl.
Cheryl Andrews Maltese. I'm the chairwoman of the Wampanoag Tribe of Gayhead-Aquina, and we're in the Commonwealth of Massachusetts. So we were the precursor, as typical in the East, of the first rendition of what the Affordable Care Act is. And the way that the Affordable Care Act has been tremendously beneficial to our community. We're a self-governance tribe, and only 25% of our membership actually lives on the island of Martha's Vineyard. And therefore, 75% live what was outside of our reach generally. And because the Indian Health Services is dramatically underfunded, stretching those dollars have been really having to become we had to be creative in how we're going to meet the needs, the medical needs of our people. Good morning, Senator Cantwell. The thing that we found with the expansion is that it provided the flexibility that we needed to be creative with that. By being able to keep allowing the tribes to participate in the Medicaid as Congress had intended several years ago as a supplement to the Indian Health Services dollars. We're able to find that the flexibility that it's provided has helped us lower our diabetes rate in prevention and education. and finding that the general overall health of our community is starting to be better because we can reach. But what the problem is with the changes that would be what we were looking at in the previous bill, and or the impacts of any sort of just repeal and removal of any of these provisions would be detrimental to us, because we simply can't afford to pay for the medical expenses for our community, and that is first and foremost a trust responsibility that the United States has to the tribes, and we're already underfunded and trying to make ends meet, and the Indian Health Service is always under scrutiny for not being able to reach, but the tribes unable to reach because of lack of funding. So if something new moves forward, what we would like to do is make sure that Indian country is held harmless from any of these provisions, as well as, providing more funding to the Indian Health Services and the tribes directly. But the former iteration was very beneficial to us. And again, it needs tweaking like anything else, but as we're moving forward, we're able to move forward together and figure out something that's going to work well for all the tribes and allow us to make those determinations for ourselves. And thank you for having this forum and being here to hear our concerns.
Thank you very much, Senator. As you've seen, we've been joined by Senator Campbell
How you
from
doing?
Washington State. Maria, if you want to, we just did very brief opening remarks and we're moving around, but I didn't know whether you wanted to.
Well, I thank you so much for giving me that opportunity. We have an energy hearing starting shortly, so I apologize that I won't be able to stay to hear everybody's comments, but obviously we're have people here and we're recording all of this, so it's so important that we're here. As you all remember, when we got into sequestration, we were greatly hampered because people didn't treat Indian country the same way that we did in the protection of Medicaid and Medicare. We can never let that happen again. And obviously, moving forward, I know Ron Allen, our great Washington advocate, is here, and the issues of self-governance. I don't know how much we're going to get into the just continued efforts by Indian country to provide so much leadership in individual sections of our country. We so appreciate. So thank you, Mr. Chairman, for giving me, and thank you for holding this. This is such an important time period for us to continue to move forward. So thank you.
And as each of them said, there, we were busy times in the Senate. She's the top Democrat over there on the Energy Committee, and so you'll see people going in and out. But just know we're recording this, and we have the staff behind us and be sharing all of this information. Chairman Allen, please go ahead.
Well, thanks, Senator and Senators. My name is Ron Allen, chairman for the Jamestown S'Klallam Tribe. I am also an officer with the National Congress of American Indians, and one of the co-chairs for the self-governance tribes that as we move that agenda forward. This is an interesting topic for all of us, and one of great concern. There's lots of issues that are of great concern to Indian country. We know that you all understand those issues and have heard them and the complexities of Indian country. But when it comes to the Affordable Health Care Act, from my perspective, it has issues and it has challenges, but they're fixable. They can be remedied. They can be adjusted. They have worked for us in Indian country. We have issues, and we have a checklist of issues that need to be remedied. Everything from the definition of an Indian issues and reimbursement requirements, et cetera, so that we can make our clinics and hospitals be successful. Times have changed for us, and how we serve our Indian community and the communities around us is changing, and we're a part of the solution. So one of the issues for us is the issue of the ability to make Medicare and Medicaid work in our community. Washington State has been quite successful. I mean, we have our challenges, but one of the most important things is as it gets implemented, the consultation process between the CMS, Medicare, Medicaid, and the programs that address health care in our respective states have to respect how it affects tribes in our communities. For the most part, we're in rural community. And being successful in the rural community is challenging. It's challenging for those of us who try to recruit doctors and nurse practitioners and specialists into our area. We have to compete against urban communities, and that is not an easy thing to do. And I have a clinic in my area. I'm a small tribe of about 600 citizens. And so the issue was, how could I build a clinic that would work in my area? Well, it wouldn't work for 600 people. It just doesn't work. So we expanded it, and now we serve well over 17,000 citizens in our community, of which that 98% plus is non-Indian. So we serve them with regard to Medicare, Medicaid, and we want to serve them with regard to Veterans Program. But we have to make sure that it works well for our programs. And it's about how we are able to recover the reimbursements for the services provided that allow us to become competitive. We have to shift our healthcare programs into a business format. We've got to make it as business. We don't have resources to subsidize it, so we need the support of the federal government. We need the support of the state government in order to make these facilities work, so that we can have quality health care. So it is a big issue for us, and we in the Self-Governance Forum and in collaboration with NIHB and NCAI, we have come up with a list of issues that we could see that would remedy some of the flaws and some of the challenges of ACA to make it work effectively in order to provide more affordable programs and affordable plans that are available. We are fortunate in Washington State to have more than just a plan. We have multiple plans in which you can access, and also the ability for us to be co-sponsors for our citizens who live outside our area. Which is common in Indian country is that a great deal of our citizens live outside our own service area. And the IHS service area has always been a constraint for us to serve our citizens outside the area. Now, the Affordable Health Care Act opens up this opportunity for us so that we can sponsor and help those who are in need of plans elsewhere. I live in Washington State. If I've got a citizen in North Carolina, I want to be able to help that citizen in North Carolina because I have a duty to them as a citizen of my tribe, and to be able to co-sponsor them is an issue. Whatever the final remedy is for the Affordable Health Care Act to improve it, so that we can have quality health care for Indian country, wherever we are, from Alaska to Florida, it's got to work for us too. We serve, we have somewhere in the neighborhood of 4 million Indians out there across America, but we serve a larger sector in America with regard to health care. And so there's a lot of issues in here. We want to make additional recommendations to the Congress and to the senators with regard to what that remedy is. Hopefully now we're going to have a bipartisan conversation that allows us to have a meaningful conversation about what are the solutions. But it's not my way or the highway, and quite frankly, we think that it can be remedied, we can be fixed in a meaningful way that helps us serve our communities and the community that surround us. Thank you.
Thank you, Chairman Allen, so much. And I think you've really hit one of the themes here today that I think we'll see is that we would like to see the Congress really reach out to tribes and be bipartisan and be included in a real debate rather than behind closed doors working on these kind of things. We're very fortunate to be joined by the Executive Director of the National Congress of American Indians. Jackie, you've done so much over the years to just educate everybody about the issues, and we're happy to hear from you today.
Great. Thank you. Anyway, I think it's on. Thank you. Yeah, I too want to join in. I think this is we woke up today with a new start, and I think this committee has always operated in a bipartisan way, and I really appreciate that. I know Indian country appreciates it. It allows us to find the best options and the best solutions, and I'm hoping that we will, that this will come to heart when we talk about healthcare in the broader sense. As you know, the big issues for Indian country, and you know it and heard it, we put together a map, which I'll just send around copies around the table, but this map just kind of once again reminds you how important Medicaid is to the conversation for Indian country. And clearly that was the pivoting conversation with the last iteration of the healthcare bill. And and yesterday when I was talking about this with my staff, I was not only looking at it from the healthcare delivery, what are the healthcare delivery issues, but really what's most important to the everyday, Native American, the common Native American citizen. What's the most important thing, and what do they need most out of their healthcare system? And quite frankly, the high dependence of Native Americans on Medicaid is really prominent. Much more than the rest of the population. So when we mess with Medicaid, we're messing with the ability for the individual Native American who's not politically engaged or understanding the nuances of the healthcare system. We're messing with their ability to be able to deal with the issues that they need to deal with. And so that's an important piece for us. And also to be able to make sure that we're messaging in a way that the common everyday Native American can understand the heavy debates that are moving forward. I don't have to remind folks, because this is the committee that remembers, that this is there is a trust responsibility. And this trust responsibility, healthcare delivery is one of those areas. And our great concern in some of the recent debates was the shifting of responsibility from the federal responsibility to the states, or to states be able to providing some of the issues. Opioids a good example. Now we know opioids is a big issue in Indian country. Alaska is the 4th leading state in opioid abuse. I come from the state of Alaska, and yet we also know that by proposals such as the last recent proposal of opioids, adding additional money in, going directly to states doesn't necessarily mean that money's going to filter to Indian country. And so direct funding of programs or additional programs in any debate is important to us, but also recognizing that those have to be also in sync with our healthcare system. The other thing is we know that there's been a lot of GAO reports, there's been a lot of conversations here in this room about some of the challenges that Indian healthcare delivery system is having. And certainly everybody's looking for solutions. And my recommendation is let's not get those Indian healthcare reform issues caught up into the debate of the affordable healthcare or the healthcare reform systems. That sometimes we overreact and want to be able to shift, maybe a shift to other providers, or a shift to mechanisms with FMAP or other kinds of things, but be able to make sure that we make those policy decisions separate from the challenges that we need to still do and address with the IHS. This is not about the system. This conversation today is not about the IHS system, but I would reiterate that we need to look at the solutions in a long-term way, not with quick fixes, not with Band-Aids, but really realize that there are issues having to deal with retention, recruitment, placement, tribal leader decision-making, and the list goes on and on. But we need to have long-term, strategic, committed, sustainable mechanisms for making that move forward. And then, of course, when we're looking at now this new day of what will the next iteration look like, because there will be another iteration. There will be another pickup of how do we deal with the repeal, or how do we deal with the replacement efforts. We want to be able to make sure that, as always, Indian healthcare is protected, that we deal with the issues and hopefully deal with the issues of the definition of Indians, employer mandate, and making sure that the protections of pre-existing conditions are in place. And so those are some of the things that we'll look forward to, and obviously we have a lot of other info that we'd be glad to participate in a dialogue with you. Thank you.
Thank you so much, Jackie, and Vice Chairman Moose. We look forward to hearing from you here.
Thank you. Miigwech buju Nijinakazudo Naogizis Ndonjabad Minasanakwan. Sammy Moose is my name. I've spent about 18 years, 17 years working specifically for the Mille Lacs Band of Ojibwe. So over the years, I've seen budgets more than I wanted to with regards to this issue and trying to build a healthcare facility for Indian country, for our tribe. Also do work for the National Indian Health Board and our area health board that we just started about 3 years ago, trying to really consolidate our word within the Bemidji area to come with one voice and to speak as the 34 Bemidji area tribes. A lot of those are self-governance tribes and are unique as in having the aspect of we have at Mille Lacs of relying on a federal dollar for health care that doesn't really meet our needs. Oftentimes, my predecessors within this role reminded me that we're one of the lowest funded regions within the 12 regions of the Indian healthcare system. So they've kind of indoctrinated me into that message in trying to advocate for Minnesota, Wisconsin, Michigan tribes. Indian Health Services is about 50% funding for the need of Indian healthcare in America. Within the Bemidji area, it's around 38%. So when I look at those budgets over the last 17 years, it's been really difficult in meeting the need of Minnesota Indians within the tribal healthcare system. The issues under Medicaid are really important to us. The partnership that we've had with the state of Minnesota and the partnerships that other tribes have had in the Bemidji area, the Great Lakes region, have been critical to meeting that gap in funding. Over the years, it's helped us to expand our services to meet the need that we have within our communities. Within mental health, we've been able to add physicians, dentists, expand services, child welfare care. As mentioned earlier, opiates is an area that's hitting Indian country really hard. Our child welfare cases have exploded in our region. We've seen them explode by 300% with regards to the opiate issue. Having resources and having an opportunity to partner with the state of Minnesota to create unique and innovative ways of getting healthcare dollars through Medicaid to help us tackle that issue for treatment, for services, for child welfare, mental health, for wraparound services are critical to our community's need and fill a big gap that's been left there through the federal system. Other areas that we are really concerned about with regards to the proposed cuts potentially within Medicaid are caps that are cost sharing cuts, are cost sharing that is potentially going to be impacted. Our ability to ensure tribal members in MSHUR or Minnesota Care is vital to our programs and us to continue to build our facilities. Seeing any types of elimination of cost sharing reductions means that we won't be able to enroll people into the health care that they need with regards to Minnesota Care or other public assistance types of care that come along down through the healthcare reform. So these areas are really critical to us and continuing to have a partnership with the federal government and with the state government to meeting the needs of Indians and the trust responsibility that they have for American Indians under the treaties that Mille Lacs and a lot of the tribes had signed in the Great Lakes region, which healthcare was a provision of those requirements. So we're here to provide as much information as needed. We're here to continue to partner with the Senate Committee on Indian Affairs, and please reach out and do so.
Thank you so much, and Chairman Bean, please.
Good chase. Ciao to Nikki. Ciao Kakak. Good chase has created. Ha Hunke. Kat Wahan. Yeah, but you go. Respectful leaders.
Thanks for coming out.
Ladies and gentlemen, thank you for giving me the opportunity to speak as the Vice Chair for the National Indian Health Board, which represents 2.2 million across the United States. In Alaska, we serve 158,000 Alaska Natives. That's 229 tribes. And Mr. Udall, I work from a small community of Cake with 500 people with 87% unemployed. Also serve on a board within the region with Search. Elected to the Alaska Native Tribal Health Consortium, serving as chair for the Alaska Native Health Board. So I have the experience of seeing right from the community to the national level. And with the cuts that I see coming at us is going to be a travesty to our people in healthcare. When we're faced with funding that's less than 50%, and you take away 16% of healthcare funding with Medicaid, How do we make up for that for our people back in our communities? I have a hospital that was built during World War II. I serve a state in some places that clinics don't even have running water. Communities that are eroding. I have many issues to deal with, but this one isn't just a Native issue. It's in the communities where the blacks, the whites, the Filipinos, and everybody else lives in those small communities that we provide health care to. And we take care of them. No one is turned away. What will affect this? Will this have in our small community? My sister-in-law is non-Native from Boise, Idaho. She asked me, what's going to happen to my health care? Well, I'm here talking to you about the same thing that we have to answer to our people who live in those communities. Don't get me wrong, I represent our people, but it affects everyone in a far-reaching way. And we have to protect this Medicaid. We shouldn't be diminishing but enhancing health care to those that we help and provide health care to. 37 years of health care tells me if we lose this funding, what will make up for that shortfall? Thank you very much.
Thank you very much. And you're absolutely right. We've made tremendous progress. We don't want to have that slip back. That's one of the things that I think we're going to hear from our additional speakers here. Ashley, really good to have you here. As I know you're president of the National Council of Urban Indian Health. Please proceed.
Thank you. So my name is Ashley Twomey. I am a member of the Confederated Tribes of Grand Ronde from Oregon, but currently reside in Detroit, Michigan. So I'm also part of the Bemidji region with Sam there. And I do serve as the president of the National Council of Urban Indian Health. There's a lot of things that the other individuals have already spoken about, and I want to talk a little bit about the specific impact that Medicaid, any kind of Medicaid cuts will have on the urban Indian population. As you know, the urban Indian health programs only receive about 1% of the Indian Health Services budget. Medicaid expansion for many of us has been a true lifesaver. Programs like mine in Detroit, we do not provide access to dental, pharmacy, specialty care, x-rays, any of those things that our clients or our community need, they have to get elsewhere. With the expansion of Medicaid, they actually have somewhere to go now. So it truly has been a lifesaver for many of us. And this is due to, we don't have access to the PRC funds that the tribes do, and so we really need our community members to be insured. And one person lost from that will make a huge impact. There are a lot of things in terms of also just the stability of our organizations. Across the country, Medicaid has provided about 1/3 of our program funding, so it's a significant cut. We have programs like our program in Portland, who has gone from 56% uninsured to 8% uninsured, solely due to Medicaid expansion. I know from my clinic, we have actually expanded our revenue now 5 times with the expansion of Medicaid. And that revenue is used to take care of those shortfalls in the budgets that we have and to truly provide those services and help our community. And so I just want to say that it's really important that we really fight for that part of the ACA. The provisions that are in the ACA that help Natives get insurance are also really important, but I know for us, the Medicaid expansion has been the biggest piece. Right. So thank you.
Ashley, thank you so much. And we have a fine young man here from New Mexico, hails from my home state here. Daryl is the administrator at the Pueblo San Felipe, and once again, a Pueblo that I think's really stepped out and tried to do the very best by all of its members. Daryl, please proceed.
Goetzi hopa, goetzi sama kutrauers, parjan sitran schutzen a hanus and the sea wash this shot sishsa My name is Daryl Candelaria. I'm from the Pueblo of San Felipe in New Mexico, and I'm here on behalf of Governor Ortiz. He sends his regards to you, Senator, and thank you for allowing us to comment here this morning. I think pretty much what I would like to reiterate with what everyone has said so far is that the Medicaid expansion is much needed and is critical within our communities, that we still maintain and continue to do so. And the reason why I say this is because a lot of our tribal clinics and healthcare facilities are taking on that responsibility. I know IHS has that trust responsibility, the government does, and I don't see Indian healthcare as an entitlement, only because of like what everyone has mentioned, that we have prepaid for this service ahead of, and we're the only population here in the United States that has done that with our natural resources, our water, our land, and it's just our population. We were high in numbers before, and of course our veterans, they continue to fight on behalf of the country and protect our way of life. But in developing our own clinics, we have the capability of sustaining ourselves through third-party money. And in New Mexico, and I believe throughout the country, we're creating these comprehensive healthcare systems, like Mr. Bean had mentioned, where non-native populations are seen at these facilities. And like in New Mexico, which is a pretty rural state, that is very important. And I want to, I guess, touch on instances where, like, we belong to the Santa Fe Hospital Service Unit. The Santa Fe Hospital and IHS facility used to be a full-service hospital where they had a maternity ward, they had specialty clinics where you could get surgery, but now it's just pretty much an outpatient clinic. They don't offer any of these, practically none of these services anymore. In fact, if a woman were to give birth, they would send up to St. Vincent's in Santa Fe or in Albuquerque Presbyterian Loveless, and it's Medicaid that pays for much if you don't have private insurance. So, again, maintaining that is very critical. In the state of New Mexico, with respects to mental health, and I think sometimes that gets lost in the scheme of things, where mental health in New Mexico, unfortunately, the state of New Mexico is not meeting the needs of our mental health patients there. And tribes such as the Pueblo of San Felipe has, stepped up. We've stepped up and provide a program, and our mental health initiatives has received accolades around the country, like from SAMHSA. We've developed like an equine. We have an equine center where children are seen, and of course what we need is sustainability, and where do you get that but from third-party money, which would be from Medicaid. So, I think it's very critical that we maintain this, and with all due respects, Chairman and Senator, we've certainly wished Mr. McCain well in what he's going through, but this morning when I heard an update on his condition, I thought to myself, where would he be if he was at an IHS facility? If he didn't have the insurance that he has, none of us won't be so unfortunate to be, again, I don't know what exactly is going through, but that's the reality that we live with every day. And I wish that people such as yourselves and your colleagues could come to us. Yeah, we're here speaking to you in our nation's capital, but come to us in our communities and see what we're going through, what our elders, what our children. And I don't think if the general population in the country saw, the type of facilities we go through, they will be appalled. They will not, we're the first citizens here in this country, yet we get second or third rate medical care. And that's the reality of this, Chairman. But again, I think transferring this to the states in block grants would be devastating to us, only because as an administrator, I already see that happening even with our education funding. The states get impact date money, but very little of that is funneled down to the districts to help our students. And I believe that medical care will be exactly the same thing. We don't have a treaty with the state of New Mexico. The state of New Mexico doesn't have a trust responsibility to us. The federal government does. So again, please express this to your colleagues, and thank you.
Thank you very much, and please send my greetings and best regards back to Governor Ortiz, and look forward to seeing him out there in New Mexico at San Felipe. And you're absolutely right. I mean, if Americans saw the health care that is out in Indian country, I think they would be totally appalled. I mean, we've made some progress, but I think that the basic takeaway people would come away with is that things are in bad shape and they need to be dramatically increased. We have now 2 members of the Turtle Mountain Band of Chippewa Indians. I don't know, Wayne's the chairman and you're a councilwoman. I'm going to defer to you on the protocol here of who's going to start. Okay, thank you. But you're both
okay, here we go.
Speak. Good.
Thank you very much, Senator Udall, and everyone else that's here today. We appreciate you taking the time to listen to Indian country at this time. We had a phrase in Indian country, and especially in our area, we call the "Don't get sick after July."
Yeah,
because there any money. The money.
You got it. You got it.
Yeah. So that's been the phrase that we've used and used for quite some time. Today, in Turtle Mountain, we're a little bit different than some of the other areas are. We have third-party billings. We have, I'll get my glasses on here. We have 33,300 enrolled members of our tribe. We have around 15,000 that are actively receiving services within our reservation. We're a small reservation, a 6x12, but we're densely populated. We're going to start stacking now pretty soon here if we don't get some more land. But one of the things that we have going for us within our facility is that we have a lot of Native Americans, a lot of our own tribally enrolled members, about 370 that work within our facility, 340. So we have homegrown doctors, we have homegrown RNs, LPNs. We have a community college which also offers these programs within our community, so some of the people are able to go there. We also have University of North Dakota, which is 140 miles away or 50 miles away, which has an InMed program. So a lot of our people have went there as well and have come back home to live and are practicing there. So we have a little bit of a different situation probably than some areas have. We do have a high poverty rate of 70 to 75%. We have an unemployment rate of 70%. So this has helped address some of that, the Medicaid dollars. Just to give you an idea, our IHS budget is approximately $24 million a year, but our Medicaid budget is $27 million a year. So we've taken $27 million in Medicaid at this point in time. We all know the baby boomers are getting here, and I'm one of those. And so we've got a lot of those that are in our area. So that $27 million, if we can continue doing what we're doing, is going to rise quite a bit over the next number of years. So Medicaid to us is crucial. If we lose that, we're devastated. We've done a lot of things with Medicaid. We've purchased a lot of services, a dialysis. We've got a dialysis center. We're looking at a cancer infusion center that we're doing. We've also done a lot of things. We've renovated our healthcare facility. We've put in 26 acute care hospital rooms. We've renovated our emergency unit. We've provided triage evaluation, clinic and registration renovations. We've also purchased medical equipment to provide better services. We've also training staff with this kind of thing. We've put in wireless throughout our facility, so we can start looking at getting doctors, or at least internet, being able to talk with someone else, another surgeon or whatever it is, somewhere else in Minneapolis, for instance, if we have someone that requires that. So we're able to do the things that we wouldn't be able to otherwise. We have another little town about 18 miles away, which is 95% Native American. We are looking to expanding our dialysis into that area, so the people don't have to come 18 miles to get this. When I mentioned cancer infusion center, currently we transport our patients to Grand Forks, which is a couple hundred miles. It's a 3-hour ride. And who wants to ride in 3 hours after you're done with those types of services? Whether it be the cancer, what do we? Yeah, just the treatment, to be able to, because a lot of the people get sick, really sick after they receive the treatment. So if we can provide those treatments at home in our facility, that's great. But we couldn't do that without the Medicaid portion of it, okay? So those are some of the things that Medicaid is doing for us. Staff, we're all experiencing the problems we have in trying to recruit staff to our areas because we're rural, we're isolated. We're doing some of that because we are home growing our own people, but we still have to get specialists out there. We need cardiologists, oncologists, orthopedics. Those are the specialty kinds of people that we're contracting with to do this through Medicaid. We're doing this with a hospital called Sanford, which is the largest medical facility, providing facility in North Dakota. We're bringing them people in rather than bringing our people out. And we're fortunate enough that we have a lake there called Lake Metagoshi, which is not too far. They have cabins there, so they can come from there over to the hospital and go back and do the services that they need to perform. So we are doing a lot of things with Medicare. It lets us do a lot of things that we wouldn't normally be able to do. And so, like I said, that we need Medicaid. Otherwise, we're not able to function.
Thank you so much, Mr. Chairman. And Councilwoman, we're also joined by Councilwoman Alice Lunday. Please, Alice, proceed.
Yes, good morning, everybody. I appreciate everybody's comments here, and it's very educational, too, to hear a lot of the issues you're having. It's the same issues that we're having. We have our Indian Health Service. We are located in the Great Plains region. I'm not sure if the chairman had the time to say that, but I'm just here to support the chairman and in all his efforts. And I thank you all for allowing us to share our information. There is a handout here that we have with some of our numbers on there, and some of the data that we collected. The data we receive is from our Indian Health Service CEO. She's an enrolled member of the tribe, and we receive monthly data from her as tribal leaders. And in with the expansion of Medicaid, we have had a rise of 9% of individuals served. An increase in tribal members with private insurance is a rise of 9.4%, and a reduction of uninsured by 14.05%. In fiscal 2012, we had 53% of our service population uninsured, and we are now at 38.99%. Our staff does an excellent job. They do a lot of outreach to get people to sign up, and they go where they need to go to do that. They've done an excellent job. Like to reiterate what the chairman said, with our third-party revenue collections, in 2013 we were at 17 million, close to 17 million. In 2016 we were at 24 million. And now our projections for 2017 were projected to be at 27 million. That actually exceeds what we do receive in our appropriations. And another thing I wanted to mention too was in the month of June, we've serviced 12,974 in the clinic, just for the month of June. And in the emergency room, we serviced 1,100, just for the month of June. We are a very, very busy clinic. Like the chairman said, we have about 33,300 enrolled members, and of that, roughly half are actively receiving treatment at our facility. So, I mean, I guess I wanted to reiterate that because we are busy. And I'm very proud of the work that they have done there at the facility. With the Affordable Care Act, Medicaid expansion, you know, it has impacted our funding and our resources that are available to our people. It has increased the healthcare services, purchase referred care services, the revenue. Did you tell me here in with the purchase referred care services, we had in 2015 8,372 referrals, and now in 16 we were able to have 11,074 referrals too. So, and we are able to service, like the chairman was saying, you didn't want to get sick after a certain time. Well, we don't have that problem anymore. So we are able to service our priority 1s, 2s, and 3s. So people that really need the service are able to go where they need to go. So it has impacted our healthcare service, and we are happy to be here to share this information. Like, did everybody get the handout? I guess we've shared some of our data with you on our private insurance, Medicaid customers, uninsured customers. We did go down in uninsured customers because we had like our college and our casino, they were changing their providers, insurance providers. So we had more of those employees coming to the Indian Health Service that weren't covered. But we need our third-party Medicaid services to be able to help our people, to continue to help them, to give them specialty care, send them where they need to go, transporting them. I mean, as leaders, you know, it is our job to make sure that we are protecting their rights and providing quality health care. And that is our goal at IHS, is to provide services and improve quality of care for our people.
Alice, thank you. Thank you so much. And let me just say to all of you, after sitting through your complete set of testimony, you just make such a powerful case of why the Affordable Care Act has made great progress, how we've moved forward. There are many additional things we know that need to be done, and we need to make sure that we can continue on the road of progress, that we don't roll this back. And I think you all have made that case very powerfully. We're now joined by my very good friend and probably the person I've known the longest in the United States Senate. Oh, welcome, Senator Tester. Good to have you here too. That I've known the longest. Heidi Heitkamp for I think close to 30 years. We go back as state attorneys general, where we always took the attitude, you know, you don't sue the tribes, you work with them. So let me just ask one question, kind of a follow-up to everybody. Darrell mentioned access to culturally informed behavioral health services. Mm-hmm. And I'm wondering, are your communities able to support more culturally informed care under the Affordable Care Act? And what additions to the Medicaid program would support more culturally informed care? And as soon as I hear from you, then I'm going to turn it over to Heidi, who's going to chair. I'm going to try to get a question in at another committee and then try to make it back here. And you'll also hear from Senator. Why don't we hear from these two? Go ahead on the behavioral health services first, and then we'll come to Heidi and John. And make sure everybody, we're recording this, so we want you close to the microphone so we can get it down, and we'll be sharing it with everybody and have it be a part of the record. Darrell?
Thank you, Vice Chair and Senators Keitman and Tester. There in the Pueblo San Felipe, we believe that our priority is to deliver our culturally competent curriculum in dealing with our mental health care services. And we all know that the horse is significant to Native Americans across the country. And by establishing and creating the Equine Center, it has definitely affected how we deliver services to our community and especially to our children, because that's who we mainly treat there at our Equine Center as our children. And so we work with the local schools, the BIE and public schools where our children attend. And so we not only use the Western form of mental and treating mental health issues, but also our own belief system. And for us, that has been successful in bridging those two and bringing them together, and how it's affected, or how the Affordable Care Act has come into play was our ability to bill for these services, to use third-party money, and also in developing a program where we can sustain it ourselves. You know, whether if this goes away, at least we'll have a mechanism. But I know Medicaid actually has a lot to do with this, and by us having the ability to have certified and licensed clinicians there. But also we talked about human capital and building our own. So we're encouraging our youth to go into the medical field, either in healthcare or also mental health. And so that builds up that capacity. In fact, we're here. I brought 3 of our interns here from the Pueblo San Felipe, and if they can,
Oh, good.
three of them stand up here. We have Quentin. On your left, we have Quentin Candelaria. In the center, we have Logan Chavarrillo and Jordan Valencia. And they're actually interning in our tribal administration. They're tribal administrator interns for the summer. And so, you know, when we talk about building capacity, our tribal council has had that foresight to engage our youth into what we're doing. And my task this week is to show them this is what we do when our tribal leaders come to Washington. You know, we engage with our national leaders. They have that trust responsibility where not every American can come in here and engage in this type of setting, which I think is what our youth needs. And again, going back to mental health, it is critical that we continue the Affordable Care Act. And I'm going to stress again, this is not an entitlement. It's not an entitlement. We paid for these services, you know, before with our land and water, and why should we relieve the federal government from its trust responsibility? We're going to be here. We're not going anywhere. And so I just want to stress that to our national leaders from my council and my leadership. Thank you.
Thank you so much, Daryl. And I want to personally welcome my chairman, Chairman Kaplan and Alice. I know you came here on short notice, but I think it's absolutely critical. And I wasn't here, Chairman, to hear your testimony, but some of the smallest landmass, but the largest population, and it creates real challenges. And I know you guys are doing everything that you can. I'm going to, recently at a hearing, something happened that doesn't happen very often, and that is John Tester lost his temper. And honestly, it doesn't happen very often. He's usually very measured in his questioning and very respectful. But there comes a point when if we don't start yelling really loud about what's happening, if we don't start telling the truth that you just told, Daryl, which is this isn't an entitlement. There's a treaty obligation here on health care. This is a different way of fulfilling this treaty obligation. and we need to get more people to figure out. I was looking your insurance rate. You still have almost 40% of your patients who don't have any insurance at all, and we'd love to see. I mean, what percentage? And I won't get into that because I want to turn it over to John. But think about this: what percentage of those folks actually would qualify for Medicaid funding if we could get them to make the application, or make the application much simpler? To me, that's the trick here. I think people are afraid of listing all that when you start talking about what's revealed on those applications. And I think a lot of tribal members who I talk to, I encourage to sign up for Medicaid, say, why should I sign up for Medicaid? I've got a treaty right. Why should I have to apply for this? And so we have to change how we look at Medicaid expansion in Indian country, because it is different, in my opinion. It is different. And Dr. Warren, who is at NDSU, is doing a great job trying to come up with some ideas. He talked to Mary Wakefield, was the deputy HHS secretary. Talked to her about those ideas. I'd love to continue to pursue those ideas. But our first challenge is not to take a step backwards. And by repealing the Affordable Care Act, we take a step backwards. And let me tell you, if you take a step backwards in a lot of the places where you're trying to provide health care, you fall off the cliff. Right? You fall off the cliff. So you better be looking behind you before you take that step backwards. And so we've been fighting this fight forever. I think you're well familiar with Senator Dorgan, who really began to highlight the challenges in Indian health. But we've got to figure out how collectively we advocate for what was bargained for, which is a treaty right to health care. And if we don't do that, if we don't continue to insist that we get that equitable, fair treatment, we're going to be falling off the cliff. The other thing I want to say before I turn it over to John is I'm deeply concerned, not just about whether it's culturally sensitive, but that we are, in fact, adopting a model that deals with the challenges. We all know that chronic disease is rampant in Indian country, that it's exacerbated by addictions, it's exacerbated by diet and diabetes, and that we need to have a different model, a different look. But we need to have a cooperative administration that doesn't cut Indian health 6%. I mean, again, a step backwards off the cliff. And so I want to applaud the chairman or the vice chairman for having this roundtable. I hope that we can build from this, because you all spent your time coming here, that we can build from this a unified voice of how we advocate for health care as a foundational piece. It's so interesting to me. People say we need economic development, we need jobs. Guess what? That's true. We desperately need economic development and jobs, but we need a population that is healthy enough to work. And if we don't have that, if we don't look at all of this, we just silo these programs, we're going to fail. We are absolutely going to fail. And so thank you all for coming. Thank you for sharing your thoughts. I have some questions that we want to get on the record, but I'm going to turn it over to Senator Tester, who really is a very nice man unless he's questioning Indian health.
Thank you, and thank you. First of all, as Heidi was, or Senator Heidkamp was, what the hell is going on? Senator Heidkamp was visiting. We've said this before, but if you get outside the Indian Affairs Committee, I'm not sure that, and you did a poll, I'm not sure that there's a lot of folks out there that knows what trust responsibility is, or self-determination, or sovereignty. And so it is definitely a educational process that we need to continue to go through. And I will also tell you that after being here for a number of years, I've always questioned whether the BIA and the IHS have the best people in them. And I'm not talking about the folks that are on the ground, I'm talking about the folks back here. And it is blatantly obvious after last week's hearing that we're not going to get anything done with IHS in particular, but I'm not so sure with the BIE either unless we get better people in there that are willing to listen to folks on the ground, or willing to move forward with a budget that works. There's a couple things that I was hoping you guys might be able to answer, and if you don't, that's fine. You're at a different scope than the guy last week. But one of the questions that was asked is that with Medicaid expansion, now it's impacted 7,000 Native Americans in Montana alone, 77,000 Montanans. But 7,000 of those were Native Americans who were able to take advantage of that program and extend some of that Indian health dollars further. And I don't know if you guys can speak to that, how that's impacted your, where you live or not. But it would be interesting to know what's going on the ground. And I don't want to get into a debate like Senator Heitkamp was talking about, well, we shouldn't have to sign up. We are where we are, so we've got to figure out how to get health care for everybody as best we can. The other thing that I would love to know is if IHS or anybody is working on prevention in Indian country in a significant way. I mean, everybody works on prevention. You know, I get told all the time I got to eat less meat and that kind of stuff. But I don't listen to it, unfortunately. But is there people working on, you know, diabetes is rampant in Indian country? Or are there people that are working on prevention? Prevention is kind of the low-hanging fruit in my mind as far as improving quality of life and saving a lot down the line. And then the last thing is that you introduced some interns. There was components of the Affordable Care Act to increase more healthcare professionals on the ground. Have you been able to take any advantage of that, or have you been able to see any opportunity for advantage in that, either in MDs, PAs, RNs, however, you know, medical professionals overall? And then the last thing would be just this. I think it is really important now more than ever because of severe cuts in Indian health that you guys are vocal. It is just really important because I don't know what's going on in each one of I don't know what's going on where you live, but I can tell you that with the drug addiction, with the high levels of crime, with this school system that needs some attention, and we'll be generous when I say that, with issues that revolve around water and housing, healthcare is something that is pretty basic to getting all those other things solved. And so we need you to be as vocal as possible, talking about how important this is for your people, because it is. I mean, if we're gonna eliminate poverty levels in Indian country, it's got to start somewhere, and it might as well start with health care. Kids can't learn if they're sick. People can't work if they're sick. The list goes on and on.
Can I just add to that? One of the great frustrations that I have is that Washington Post will do a big story about, you know, the child welfare, and that will be, you know, all the talk. Now we've had the Wall Street Journal do a whole series on Indian health. This is an old story. We've been dealing with this for a year and a half, actually. So this isn't a new story. This is an old story. But there's always this kind of surge of, oh my goodness, we need to deal with this, and then it dies down. Yep. And then you become again the asterisk, right? Yeah. You then we don't have sustained outrage. Mm-hmm. And we need sustained outrage to fix this problem. So I want to just echo what John said, which is we need now more than ever sustained advocacy. And we need people to understand what this program, what the expansion of Medicaid means, and what the additional needs are. And we need a surge of help. Mm-hmm. If we're going to work to stop the cycle and save the next generation. So I'll just add my thoughts to that.
And one more thing, and then I'm going to be quiet. That is that I know that, and this is not political at all, I know that there's people on both sides of the aisle that reach out to you, and I think that's a good thing. I really think it's a good thing. Bipartisan is the only way we get things done around here. I would not sugarcoat any of this stuff because it shouldn't be sugar-coated. What's going on in Indian country right now from a health standpoint, if it was anywhere else, we would not be accepting it at all. Mm-hmm. So make sure you tell not only Heidi Heitkamp and John Tester, but anybody else that you can about the crisis that's going on with healthcare in Indian country. It's really important.
Absolutely. I'm Cheryl Andrews Maltese. Sure. Sure. My name is Cheryl Andrews Maltese, and I'm the chairwoman of the Wampanoag Tribe of Gayhead-Aquina in Massachusetts. And I had the distinct pleasure of sitting on the other side of the table working as senior advisor for the Assistant Secretary on Indian Affairs, at which I certainly can appreciate the frustration that you felt with not getting answers to your question. And the reason I'm happy to be back as chairman of my tribe again is because it allows me to be unfiltered. The answer to your question is that the Indian Health Services is grossly underfunded. That budget will not help. And therefore, what we're faced with by trying to be able to bring back or maintain the Medicare expansion for tribes is critical to us because we're so grossly underfunded. And Congress wisely had utilized the expansion of Medicaid to apply to tribes so that we could supplement those dollars that we currently do not have. So it's critical for us to be able to continue with that. Prevention, as far as the questions that we were asking, we work very hard at prevention because obviously it's less expensive to prevent problems than it is to treat them in the long run. Between the diabetes and cancer issues that we have 25% of our tribe that is on the island, but 75% is not. So we have to be creative with how we outreach. And as far as working with what we have now, it's far superior to what we had before, but ultimately we have to make sure that we're protecting the progress that we made, as you said, not sliding backwards. And we have to make sure that we're improving the marketplace expansion for American Indians and Alaskan Natives. Because when you can't treat your people on a remote area, you have to be able to have that flexibility. And as a self-governance tribe, we need flexibility. We shouldn't and couldn't be, well, it can't and it shouldn't go through the states to make decisions or for us to access our money. We should be able to make our own decisions based upon our knowledge of our own people and our own community needs. And as far as what the other tribes are doing with bringing their young people back in and what the advantage of the educational reimbursements from the Indian Health Services, they're restrictive. And as far as I understand, it also doesn't apply for administrative positions. So how do we expect to get our students and our young people engaged and educated in healthcare when it's only the practitioners and direct service people that are allowed to be able to be reimbursed on these things? We do have some specific asks with regard to the new things, and that is, one is the permanent reauthorization of the Indian Healthcare Improvement Act. That is critical for us not to have to go back and essentially sing for our supper every few years, as well as a diabetes grant, and all those things that are embedded in that. We want to provide the tribes with the options to best determine our own needs, and we also I want to make sure that we're fixing the definition of Indian underneath the law to ensure that all Indian Health Service beneficiaries are eligible for these benefits and services. We'd like to be able to provide some relief to the employer mandate for tribes and tribal governments, because that too is a strain on us. And the OMB is always saying that you can't pay for certain things as an employer. So of course, we can't tax our own people the way that cities and towns and states can. However, we're expected to conform and comply with inapplicable regulations that are forced upon the tribes. We want to be able to improve the marketplace access for tribes. So my people that might live in Tennessee or out in Montana, they expect me to take care of their health care benefits and their health care needs. So I should be able to have that right and that flexibility to accommodate my tribal people irrespective of where they live. So
Can you explain to me what you see as the fix to that?
by allowing the tribes to be able to have the money to invest in whether it's health care underneath a regular outside
Would
provider.
the tribe buy plans on the exchanges?
We can buy plans on the exchanges for our people, almost like a health account. We have to be creative with that. Oftentimes it's less expensive for us to get an HMO for a family and pay that premium for them versus having them come to an IHS clinic or come back to us. particularly. And we also have to make sure.
I see this as similar to what we do with the VA.
Yes,
And
very
so,
similar.
So it would be really interesting to think about this a little bit more.
And-
Because we have this problem in North Dakota, you know, what percentage, Chairman Kaplan, of the tribal members, enrolled members, don't live on the reservation?
Mm-hmm.
You know,
Yeah, well, we have
Can you use your
33,000
mic,
members enrolled,
Wayne?
but we have around 15,000
Yeah.
live on
About
the
half.
reservation, so over half.
Yep.
yeah.
Yeah, and that's what it really, the tribes, like each one of the tribes represented here and across the country, we're our best advocates and we understand what our needs are the best. So by being able to fund what we need appropriately and allow the tribes to make those determinations without the restrictions of the state, without some of the restrictions of the Indian Health Services, being a self-governance tribe, that's what we do. And we're creative. We stretch a dollar like nobody else, as you all know. But we just really need to get into allowing the tribes to do that for us. And then just, you know, just preserving the Indian-specific provisions that are embedded in any of these things, any of the healthcare, the new programs or the new laws that might come out, and really help to work in that bipartisan way and making sure that Indian country is sitting at the table through these roundtables and other discussions, because it's critical that we have the input to help guide. And also, Senator Testa, as you mentioned, outside of this room, so many people don't know that it's not an entitlement, that it's an obligation and a responsibility. And it's not an unmet need, it's an unmet obligation that we have to work together to try to move forward. And I offer my time and assistance any way that I can be. Thank you.
Okay. Well, thanks, Senators. My name is Ron Allen. I'm the chair for the Jamestown S'Klallam Tribe, located in western Washington State, west of Seattle. And I'm also an officer at NCAI and very active with the self-governance movement. I just want to throw out 3 issues to complement my colleagues here at this roundtable. One is you raised a number of issues in your comments. One big issue is recruitment. We live, for the most part, in rural America. And so it is challenging for us to recruit doctors, nurse practitioners, and specialists in our particular area. So these folks, Indian and non-Indian alike, you know, go through school and they develop bills. So the issue is, if we have the ability to help cover some of those educational costs, then that can be an incentive for us to be able to get them out to our communities and to work in our clinics and our hospitals to serve in our area. One area, as we now hopefully are in a bipartisan conversation about improving the ACA Act, one of the issues I want to point out is and remind you about the employer mandate provision. So you in Montana and North Dakota, I can point to a couple of tribes who would be penalized more than what they receive from IHS because they have so many Indians working for their clinics and hospitals, and it was not intended by ACA, and those are remedies we need to fix. And a second one is a definition of an Indian that we want to correct. But I want to point out to you that Medicaid is so important to Indian country. Just as an example, I have a clinic. I'm a small tribe, 600 people, but I serve the local community at large. I serve around 17,000, almost 18,000 citizens in our area, Indian, non-Indian alike, mostly non-Indian. But 40% of our patrons, our patients, are Medicaid. So if they reduce the proposals that's been on the table here in the House and over here in the Senate, if those proposals move forward, it would devastate our clinic. It would devastate our ability to serve an underserved community, and that is a huge concern of ours.
Ron, real quick, did Washington do Medicaid expansion?
Yes.
And what if just Medicaid expansion went away? What impact would that have?
It's, I don't have the actual number, but a significant portion of the 40% I reference is Medicaid expansion. There's a lot of folks who just were, that Medicaid expansion pulled in that need the service. It would still have a significant impact on our ability to serve. Going to my first point about recruitment, we run our clinics and hospitals. Indian country runs our clinic and hospitals like businesses. They have to pencil out, and we have to have the resources in order to recruit. the doctors, nurse practitioners, et cetera, that make our operation successful. And it's not just those professionals, it's the administrative professionals as well. Those who know how to recover the reimbursables. And that's a very complicated process when you're recovering from all the different entities, including third-party providers. Thank you.
So, yes, I'd like to. Sorry. I'd like to go back to the question that Senator Udall left with and then add in what you did, which was this cultural sensitive care. Just a week ago, I ended up taking my mom to the Alaska Native Medical Center for 4 days so that she could have surgery on her eye, and stayed at the residence there. And to me, it was such an amazing example of quality cultural care when you are able to live within the facility while you're there and being taken care of. But then the food choices helps deal with diabetes, education, and prevention. There's not, you can't buy bad food. You can't buy a soda pop in the center there, and yet you had access to fresh salmon with great recipes on salad, actually showing us how to eat better. It wasn't necessarily the salmon with the rice and all the trimmings, not the good stuff, but it was actually salmon and salad. And so I thought that was a really good educational model of culturally sensitive care that I hope more people will be able to go and take a look at it. And I'm sure Lincoln, I want to applaud Lincoln and the work that they've done in Alaska to make that happen. But then when we talk about this issue of well-being and mental well-being, when I was in the Great Plains listening to some of the hearings that happened last year with IHS and getting the tribal leaders together, that was one of the greatest concerns, which was how do we deal with this ongoing challenge of the mental well-being and certainly the suicide prevention and other issues. And what was missing, what we identified, was the community health aid practitioners was no longer a vehicle in the communities as they once were, because of the certification required to be able to deal with the Medicaid bill and to be able to bill it under Medicaid. And so all of a sudden there was a gap of a provider of a service that used to be a comfort place for the community that is no longer there. And I would definitely take a look at that. Now, I know at the very end of the administration, Mary Smith, when she was there, she did a memo regarding this issue, but I do think it needs more follow-up. And it also helps us deal with this issue of recruitment, particularly building our own. Because if you look at one extension of the community health aid practitioner is the DHAT model in Alaska, which really is a great model of developing mid-level practitioners. And community health aid's the same way, getting people engaged in healthcare, realizing that that's a profession that they would want to be able to go in. And then your last, one of your questions having to deal with, the issues of the news articles and the pivoting point that it always happens. I actually think that part of the challenge is not just that, but the fact that we don't have a long-term sustainable reform plan for IHS. We have 1 million GAO reports. We're having 4 or 6 of them happen right now. I've had how many interviews in the last month? And yet we do not have a sustainable, beyond administration's long-term, short-term, long-term plan for reforms.
Can I ask, has anyone looked at the final report that Mary Wakefield did? Because Mary, who was the deputy HHS secretary,
Right.
worked with, that's when Mary Smith came in. And so Mary Wakefield was put together a plan, and now it seems like we're starting all over, right? So all this work that everybody did just doesn't, I don't know if it was a plan for long-term reform of IHS or if it was just kind of a patch.
Well,
What's your opinion of that?
There was elements in there, but what we don't have is tribal leaders sitting down with, as well as the officials, the healthcare officials, sitting down and actually saying, okay, how do we come up with a plan for all of the elements? So if there's a plan for recruitment and certainly and retention, that's included in there, but what are the other pieces? And part of the reason why I say that is when I was there at the Great Plains at those meetings that they had, and I'm certainly, our chairman here could speak to that, tribal leaders made it very clear that them being decision makers in the process is essential to a long-term fix. So how do we include the tribal leader decision-making, even when you're a direct service tribes, or as you move towards a different model of tribal leader engagement and decision-making?
Can I ask, because I know we've had in the past North Dakota tribal members who have been on the National Indian Health Association. I think that's what it's called.
Right.
Are they working towards that end? Do you know, Jacqueline?
I don't want to speak for them where they are or where they aren't, because I don't have
Is
that
anyone
information.
here on that board?
No, I'm not on the National Health Board.
Well,
But
I mean, a lot of us work with them. They are trying to put together a proposal that's supported by all the tribes. That's the problem.
So my reason for asking this question is that I mean, we could ask, but I don't hold out a lot of hope that this is going to be administration-led, a major IHS. And so I'm looking to who could do that. Obviously, we're going to be very interested as members of this committee and as people who work, but I'm just wondering.
Well, one of the issues you raised the question, Mary Wakefield and Mary Smith and folks in the last administration were trying to solve some of the complex problems, whether it's Great Plains or elsewhere in Indian country. The problem is that we ran out of time in order for it to be properly vetted with all the tribes with regard to a number of components. One was, for example, just how their central office functions versus the regional office and the resources necessary to fix the problems.
Yeah, I think we want everyone. I'm actually available until 11:30. I don't think this room's going to be occupied, so we can go a little bit over time here. So, but we want everybody to actually kind of weigh in, and so good dialogue. We're all building on what everybody's saying, so that's very helpful.
Yes, Samuel Moose, National Health
Bring
Board.
your mic close to your.
Samuel Moose, National Health Board Treasurer. I know that the National Health Board has a number of representatives from all the regions, so this actually has been a discussion that they've had, that they've pushed the recommendations forward. So they have weighed in on the issue and supported that there be some long-range reform with regards to the Indian Health Services, along with appropriations. As we were talking, one of the things I constantly sit back and think about with regards to the region that I also represent, the Bemidji area region or Great Lakes region, and in the work that I've done over the last 18 years with regards to managing a specific tribal healthcare program, and then having a lot of dialogue with regional tribal healthcare folks within the Bemidji area, one of the things we always look at and what I see with regards to the Indian Health Services system, of course, when we look at the question of what needs to happen, full funding is definitely one of those things, giving tribes the resources. When I look at our budget specifically for one tribe within Minnesota, about a quarter of my budget is made up within the Indian Health Services compact that the tribe receives. Medicaid, of course, the billing, our tribes are billing Medicaid at about 60 to 67% of their billing are made up from Medicaid. So it's a big
60%?
60% to 67%. It's a big part of their portfolio, and like you heard from Great Plains region, that it exceeds at times what IHS provides us under contracting or compacting, under direct service or self-governance. The other 50% of the pot of money is something that we're reaching for all the time through soft money, grants, other ways of doing innovation within Indian country, trying to purchase services, sell services. It's a very, I've been doing it for about 17 years, trying to put together a $20 million budget. And trying to find the other 10 million of that has been incredibly difficult. Not only to mention that IHS itself is a discretionary pot of funding. So it's been very difficult on Indian country, and especially on the Indian healthcare leadership within Indian country. I myself, every year, try to fill in the gaps, and it becomes very difficult. My leadership within my area, the practitioners who are underfunded, when we're trying to ration out care, when we're trying to identify whether we're going to try to work harder on suicide prevention, or we're going to try to provide mental health, or we're going to try to provide transportation services, at any given time, we can't do it all with the types of funding we have. So we have to cut areas. and it's very hard on leadership. And when we look at retention and recruitment, that's a very difficult thing to do with regards to the leadership who burns out because we can't do it.
It's hard enough to recruit, but then you add this stress of delivering services and not knowing whether you're going to open up the clinic tomorrow because you don't have enough money to open up the clinic tomorrow.
Or pay somebody's
Yeah.
pension or...
Lincoln?
or thing.
Thank you. My voice carries.
Thank you.
You know, I've told other senators I've been doing this for 37 years. And 50% funding just doesn't make it. We have to be aggressive at looking, and we were told to go out and get more funding from third-party billing and the M&M, Medicare, Medicaid. And our biggest fear is it's going away. The other thing is, as a tribal leader, and I think this applies to all of us, that we're only funded from year to year.
Yeah. Yep.
The VA is funded 2 years. We can't plan ahead 2 years. And then when you start having cuts and everything, we have to react. And then we have this time to wait when we have to kick in to pay for the time that's where there's no funding, and then we don't get reimbursed. There's a lot of nooks and crannies to this whole thing. But under self-governance, we've come a long way.
Yeah.
Right now, we're trying to grow our own. I serve as the secretary for Alaska Pacific University. We want to train our own people, our community health aides, our dentists and nurses. And that's just in the beginning stage right now as we talk, but still keep the university available for our young people. These are innovative ways that we're looking at in Alaska. Hiring and recruitment is very, very difficult in Alaska. We sometimes get people to the village, and if you don't have the Kmarts or the Costcos, or you don't have to go downtown or to the big shops, it's not for you. And some people will last 3 months, 3 days. It takes a special person to live in Alaska. Alaskan is the true meaning of unique. It's remote. And it's isolated. And the funding that we get, we hold on to as hard as we can. We fight for every nickel, penny, and dime we get. And that's why I'm sitting here today. I was in Detroit, flew up there to Seattle and said, we need you back here. And I just get ready for your 4-hour time difference, and here I am trying to not to fall asleep.
I want to thank you for coming because your voice is unique. I do a lot of work with Lisa, and when I complain about remote rural areas in North Dakota, she tells me her stories, and I just can't imagine the difficulty of tribal leadership has delivering services in that remote environment. I want to make one point about the year-to-year funding. When you look at the exemption that Medicaid and Medicare had from sequestration, that didn't happen on Indian Health. And so sequestration, you know, we saw the reduction in commitment to Indian Health. We saw the reduction that didn't happen in providing resources to any other population. So once again, this funding stream and maintaining this funding stream is absolutely critical. Thank you. Chairman Kaplan? Press the mic and pull the, there you go.
Here we go.
There you go. Thank you.
Thank you. Senator Heitkamp, next time, please let me know before 2 o'clock on Friday afternoon that I have to be down here and trying to get reservations. Plus, my wife is mad at me because we were going on vacation on Saturday morning. So
now I'm in the doghouse.
Now it's done.
Now I'm in the doghouse.
I'm blaming you. At least I got somebody to
I owe you one. I owe you one.
But anyway, we're kind of reiterate what we've talked about before. We have, even though we are in North Dakota, we have problems with recruitment as well, trying to get people there. We are home growing a lot of our people, as I said before, with the help of the university. They've got an InMed program that a lot of our people go to. We also have a pharmacy program and some other programs, I'm not exactly sure, at the college that we're starting, which our young people go to also. So we are doing some things to try and and get our own people involved in our medical facility. And we do have some local doctors at this point in time that are working in our facility. So we are doing some of those things. But trying to get people to come and to work there is very difficult. One of the things that you were aware of, and you are too, is that you can get one to come and work, whether it be one of the spouses, but what does the other one do and the kids do when the other person's at work? There's no social, like you said, the Walmarts and the Kmarts. We don't have those, so there's nothing really for let's say the husband is a doctor. There's nothing for the wife to do. Where does she go? What does she do during the day? She can't go get her nails done because there's nowhere to go to get that done. So it makes it difficult to try and keep people there. They're there for, like you said, a week, a month, a year, then they're gone, and you don't see them again. So that's why we have to try and get as many local people as we can to get them educated in the medical field. And for us, it's starting to work. But Medicaid dollars that we're using, we don't do it with that, but we're doing a lot of things that we've been unable to do before. Right now, we're starting to contract with Sanford out of Bismarck. We have a lot of areas in our hospital that we need specialists in. And so we're bringing them in. Rather than us taking our people and transporting them for 3 hours, and I've said this before, we're bringing the people in to do that. We're starting to do that. We're also starting a cancer infusion center, which Medicaid has allowed us to do that. We've got a dialysis center, which Medicaid has allowed us to do that. We couldn't do it otherwise. We could not do it. As I pointed out before, our IHS budget is around $24 million. Our Medicaid budget is $27 million. So we're able to do a lot more with Medicaid than we can with IHS. And we have 33,300 enrolled members, and around half of those are in our area that receive services. You also pointed out the situation where your people live off the reservation or are somewhere else where you can't provide services. We have a lot of that too. We have people that, I've got a sister that lives in Sioux Falls. I got one that lives in Fargo. If they get sick, they have to come home. And they can't because they can't receive services out there. So yes, those are some of the things that we run into also. Those are some of the areas that we need help in.
So Chairman, I do have a question. Alice put together this great chart, which I've been asking for a long time. You still have almost 40% without any kind of third-party pay, right? So what can we do to get that number up higher? Because I would imagine a fair number of those people, Alice, actually qualify for Medicaid, but yet have not registered. And I'm assuming that we're going to be able to fight back all this horribleness that's happening here and then start working on how we can make the programs that we have right now work in Indian country. So how can we do a better job here?
Well, the thing for us, I think one of the things, I'll let you get to that, Alice, in a second, but a lot of people that come to the health service are saying, you know what, I'm not going to sign up for Medicaid because that's a treaty obligation.
Right.
They should be providing me that service. And unfortunately, that's the way some of them are. They're not, and it's my age, the older generation, I'll say. And I hate to put myself in that category, but it does happen. But anyway, those are some of the ideologies that some of these people have, is that they have an obligation to provide me a service. And I'm not going to give them the opportunity to bill my insurance or bill Medicaid. I'm not going to provide them the information. So that's one of the reasons. And I'll let Alice go ahead.
Outreach, I think that's the factor there. I know that they've done a lot of outreach, but I know Shelley Harris, our CEO at the Indian Health Facility there, said that they are going to be hiring a few more people to start doing that. So she recognizes that we need that.
One thing that I would be very interested in, and you can comment too, is how we can make the application process work better in Indian country. For exactly the reasons that we've been talking about here, which is that this is not an entitlement program. You're not in the same status as people who would otherwise have health care. And then getting to the Medicaid registration. So many times, and you know this, Chairman, thank you so much, Lincoln. You know this, Chairman. Mom gets sick. The only place she can get health care, she takes the kids out of school in Fargo, drives up to Turtle Mountain, and then you've got kids out of school and you've got disruption. And so, this is a critical piece, making sure that we get members who qualify signed up so that you can do third-party billing on the reservation, but they also can access health care off the reservation, and Ashley will get to you. So, Sam, you get a point here?
Just a couple points I wanted to make. With regards to, I agree that outreach is critical. Within the state of Minnesota, the state had worked with tribes to create tribal navigators as a way of creating access points within the tribal system for people to get signed up. It's worked really well. Of course, we could definitely work on some sustainable plans with regards to how do you support those tribal navigators, because oftentimes tribal members feel more comfortable giving their information to a tribal member than they would a county or a state.
Better training of tribal navigators.
Correct.
Yeah.
So I think that's an incredible access point, or that creates a thing. With regards to recruitment and retention, of course, our area that we've utilized within that a lot of tribes utilize, of course, is placement. So if you could somehow continue, I know IHS has some limited resource with regards to loan repayment, and unfortunately, some of those are there's still a tax on those loan repayments. We would definitely advocate that tax be lifted. And then HRSA has been incredible for tribes of creating sites for loan repayment. I know that our tribe, the tribe that I'm from, the Mille Lacs Band of Ojibwe, has utilized a number of spots for our clinics to bring people in. Of course, there's a limited time with regards to those, and we do see a window of turnover there, but it does get people into those tribal sites, and it definitely helps Indian country.
Yeah. Mr. Chairman?
Senator Heitkamp, a couple of things. First of all, with Medicaid, we're getting a lot of people that live in the city, like Minneapolis, that live there for 30 years or longer. Those people are starting to come back because they don't have insurance. And they're bringing their kids and grandkids with them. And so we're getting that influx of people that need these services. And so we have to be able to provide that service. And sometimes with the limited IHS dollars that we have, we'd never be able to do that.
Right.
Never be able to do it.
No. I mean, this is the Medicaid story in Indian country is the least told story of all of the potential damage that will be done by a straight up repeal of the Affordable Care Act. And so that's why we're here, is to tell the story, but also to talk about not how do we fight today's fight. Let's make sure that when Tom and I are old and gray, Tom's a lot older than I am, old and gray, that we actually have done something. We actually have created and that's why I think this idea that let's look systemic at an overhaul of Indian health and how that works. Daryl, or
Another
Alice?
big issue we have with recruitment is housing.
Yep.
We have a lack of housing within our IHS facility and in the private sector as well. No one's building homes. It's hard to retain our employees because there's no place for them to live.
Part of this, I want to make the point, when Secretary Castro came to Turtle Mountain, everybody talks about Pine Ridge. What his staff said is what they saw in Turtle Mountain was worse than Pine Ridge. And so you don't create an atmosphere if you don't take care of the schools. I think Senator Tester said it best. You don't take care of schools, you don't take care of the housing. That just adds to recruitment problems. And you want to build housing for middle class folks so that they can live and create and do what they want to do back home. And so that's why I'm saying we just can't silo all these problems all the time. We've got to look holistic at what we need to do. And please apologize to your wife for me, but this is a really important discussion. Daryl, you want to add to the dialogue here?
Sure. Here you go. For the Pueblo San Felipe, we have sort of like a hybrid program where our dental, our pharmacy, our behavioral health, we've gone 638, they're contracted. Our main healthcare medical clinic is still under IHS. And although we're moving in that direction in contracting the whole program, we have some challenges that we have to work through with IHS local and maybe regional, for instance, EHR and RPMS. In order to build upon a sustainable program, we need the ability to collect, through Medicaid and through private insurance and whatnot. And so there are those bureaucratic red tapes that we have to work through in order to move forward in that. And with recruitment, if you look at the state of New Mexico, a map of it, you see Santa Fe in northern New Mexico, Albuquerque in the central part of the state. We're like right in the middle. We're half an hour between the two cities, but we still have our challenges in recruiting personnel there, and including doctors. And what the fear is, and I probably can say this, is if the tribe were to move toward contracting, those IHS employees that are there right now, that are the commission corps and what have you, are kind of fearful because they fear, okay, well, if the tribe takes over this facility, are we going to lose all our benefits, our pension and everything, and what can we do? Because some of these people have been there for so long and have worked with our youth to our seniors, and so they've built that trust in the community. Our Pueblo there, about 80% of the tribal members still speak the native language. So when we say 80%, yeah. And so when we talk about delivering culturally competent healthcare, then our own personnel, our own healthcare providers, they also need to converse in our language. Right now, how we're doing that is we utilize like the CHRs to go out and with the public health nurses, and they translate, back and forth. And Mr. Senator Tester had asked a question about prevention. And what we're doing, what we've developed there at the Pueblo, is to engage the youth and the seniors. How do you prevent these health disparities when the youth are actively engaging with our seniors, and they talk about growing up in the Pueblo, at the time when these changes were occurring from. We're an agricultural society, and historically we've been farmers. What happened, and when we got the fast food industry, the sodas and all that, and a lot of us that were raised on that, where our seniors were at the tail end of them still consuming a corn-based diet, with also lean meats and whatnot. And so, that's important. And then we talk about food sovereignty also.
Right.
Reclaiming, what we produce.
I just want to mention a report that was handed to me over the weekend. The Shakopee contracted, I don't know if you've seen it, they've contracted for a report on how we can make the Farm Bill more responsive to exactly the concerns that you're raising. It's a pretty lengthy report. I haven't had a chance to go through all of it, but I want you to know I will be sharing it with my colleagues on the Ag Committee, because again, we can't silo this. I want to make a point, maybe before Ashley talks, which is you come here, you incur all the expense, you sit at this table, you tell us this, but sometimes I'm sure you feel like what happens in this room stays in this room. It's kind of like Las Vegas, right? What happens in the Indian Affairs room stays in the Indian Affairs room. We're going to go to the floor today and raise these issues. We're going to try and elevate and amplify what you're telling us today. So it's not without, we're serious about this, I think, is what we want you to understand, that this is not the end all and be all, that this will go out of this room.
And that's what we're concerned about.
Yeah. Right.
There's going to be action, or at least helping us.
Yeah.
what we're saying is that lip service. We don't want to come here and tell you this stuff, but that it stays here. No, we want this to go out, some of this to go out.
Yeah.
To be able to express what we're all experiencing within our areas.
And I just wanted to make one comment here. The special diabetes program for Indians has really helped and has worked in our community on I'm sure with many of the tribes. And unfortunately, it's going away. And I wish, more funding could be put into this program. Again, it's benefited us greatly. And kudos to the MB3 Foundation because they're out there advocating for our youth also. We work with them quite a bit with Nota Begay. Thank you.
Ashley, you get the final word here.
Okay. So thank you for this opportunity. I wanted to start off with talking about the question of prevention. I think it was mentioned earlier that we really can't afford to not do prevention. That's where a lot of our efforts have to go to because of the funding level that we have. We have a motto in Detroit at our clinic that culture is prevention. And culture is a big part of that, especially when you look at mental health and substance abuse services that we provide. And I think it was asked how we can improve those efforts for prevention and culture within, the ACA as it is now or in Medicaid. I know the state of Arizona has been working on an 1115 waiver to cover traditional services so that they become billable. I'm really close to the border of Canada, and we do a lot of work and go over to study how the clinics and the tribes are operating these services in Canada. And they're able to get funding for their traditional services. And that's a big piece of what's missing, I think, here on the United States side. As far as some of the prevention services, we're really big on fruit and vegetables. We prescribe fruits and vegetables to our clients. We provide them monthly boxes of fruits and vegetables because there is such a lack of access to grocery stores. In Detroit, we suffer from some of the same issues that some of the rural areas have. About 3 years ago, we finally got our first grocery store, and it was a Whole Foods, which is not really affordable for most people. So the other thing we're fortunate to, this year we actually took over a 3-acre garden and farm and orchard. So we're actually part of that process of bringing that food to our community. One of the other things that I wanted to talk about, I know it was, there's a little bit of a discussion on some of the leadership issues within IHS. I think part of that and part of the stalling that we have in making any efforts is we don't have leadership. Since 2015, we have had 5 different directors. Name one for-profit company that would survive with 5 different CEOs in that short of a time span. We can't move forward. A perfect example of that right now in terms of what the Urbans have been doing in terms of working with the IHS director, we've been very fortunate to have budget increases for the last 3 years. It is currently the middle of July. I do not know how much money I'm going to receive from that increase, and I will have until the end of September to spend it. I will be lucky to get that 2 weeks before the end of the fiscal year. So I cannot plan even within a 1-year period. So while the VA has the 2-year and we were talking about needing us having to plan year to year, at this point I'm going to be planning in weeks for something that is not sustainable. And that's a really big issue for us. I think the other, they talked a lot about the navigator training. I think that's crucial. We were very fortunate that we had a CMS navigator grant. I was actually a navigator. I was navigator by day, CEO by night, and really got that opportunity to meet one-on-one with these patients and see people in tears of joy of getting coverage for things that they have not been able to get coverage. And so firsthand, I've really seen that impact not just on my bottom line, but on that person-to-person connection. I think one of the big issues for us too, as Urbans, and I know I've testified about this too, is we're really concerned about the 100% FMAP for Urbans. We're concerned that some of the changes that have come out in the bills in terms of Medicaid cuts and other things that some of the tribes may end up getting protected from, that we're going to get left out of because we're not a part of that process. And so that's a really, in terms of what's kind of out there right now, another big issue for us. So thank you.
Thank you, Ashley, and thank you for all those comments. You can kind of see this coalescing. Before I turn it over to the Vice Chairman, I'm going to just tell a story. I was invited to sit on a panel at the Youth Summit. President Obama brought so many tribal youth together, and these are traditional kids who very, very respectful. I mean, incredibly, culturally grounded, some of the best and brightest, and it makes you hope greatly for Indian country. And at the end, Sylvia Burwell, who was on the panel with me, said, I really want to work with the youth of Indian country. And she said, like for instance, I run Indian Health. The room exploded. I mean, these very culturally sensitive, respectful children. One person goes, that's the place where you go to sit and wait to die before you get health care. Literally shouted it out at her. And I think that it's unfortunate that it's unfortunate any of this happened, but it's unfortunate that I think the past administration came to the awareness that this is a system that is failing greatly in too short of a time to really begin these dialogues. And so I don't fault the administration, but I will fault us if we don't continue the work that was started. And so that's why we're here to talk about that we need a different result. You guys have come up with great ideas. I think we've got to figure out how do we build kind of a broader coalition of great ideas to do what's been suggested here, which is to look at an overall revamping of Indian health and what would that look like, rather than just patch it together. And the one thing, and you saw it when Senator Tester used that great temper of his in exactly the right situation, you saw what the frustration was, that it's not enough to have competent professionals at Indian Health. We need to have advocates, and that's been a problem all along, and that's a bipartisan problem. That is not new to this administration. And I don't know why anyone wants a job heading up Indian Health if they aren't going to be that advocate, if they aren't going to scream from the rooftops. And we aren't going to confirm anyone to that position without a sense that they will go up against, be the strongest fighter for health care in Indian country, not just maintenance, but fighting and advocating. So you have our commitment on that. And with that, Mr. Chairman, Mr. Vice Chairman, thank you for pulling this together. And I look forward to continuing to work with you. And just a final note, one of the things that Tom did before the end of the last administration is he brought Mary Wakefield in, and we got a debrief from her. I think that we've got a lot of opportunity to build on some of that work, which you guys participated in, but take it to the next level. Yeah.
Heidi, thank you so much. She is a great champion for tribes and Native nations all across the country, and I really appreciate you stepping in and helping us keep this going and make a full and complete record, which is what we've done today. And I just want to thank all of you for spending the time, traveling so far, the expense and all of that. This has been a very, very constructive dialogue and discussion. And I want to repeat in a way, in just a little bit different way, what Heidi said about your voice is not staying in the room. I mean, I believe you're really making a difference being here. And it's like, in a way, you have Bobby Kennedy talked about a pebble dropping in the lake, and it first starts as a ripple, and then it builds into a wave, and then it builds into a tidal wave to wipe out this ignorance and resistance to giving you a full health care system. And that's what your voices are doing, and they resonate today throughout the Capitol. I'm leaving here. I'm going to have a press conference statewide with all of my New Mexico people, and we're focusing on what you said here today. And then, as Heidi said, we're going to the floor this afternoon. A number of senators on the Senate Indian Affairs Committee that really care about tribes, and we're going to make the case once again. So we're going to fight tooth and nail, and we're not going to let them roll back that progress we've made, and we need, as you know, to make a lot more progress. Thank you very much, and at this point, I don't know if we say the hearing's adjourned or whatever. It's around.
Oh, what time is the, are you
Yeah,
guys
please,
scheduled?
go ahead, Wade.
No, just what time are you scheduled to go on the Senate floor? And how do we get on there? I've
Yeah,
never
we
been
can
to the
get you
Senate
on
floor
the,
before.
we can get you in the gallery.
In the gallery, so it's 3:25.
325, yeah.
So if you're still in town, maybe someone from the committee can get you all badged up, so they'll take you over to our members gallery, you know, which will be easier, because a lot of times if our people go to the regular gallery, they can't really see us. So being across the way is important.
It's better.
So you're all invited to hear the comments, but I think to continue this discussion and this dialogue. Thanks, Wayne.
Thank you.
Thank you.
Thank you.
Thank you.
Heidi, do you want to?
No, I don't. Those are yours.